The best practice is the lowest effective dose, your third psychiatric consultation. Medication should be considered only after exhausting alternative treatments. You need a psychiatrist to guide you through the medical literature. In most cases, the best practice is the lowest effective dose of medications. When higher doses are used, there must be a significant and substantial justification for using more than the lowest effective dose. Massive doses of antibiotics for rapid resolution of fulminant or rapidly progressive infection in an immune-compromised patient is an example of a reasonable exception. In psychiatry, massive doses are rarely justified because of the risk of respiratory arrest, cardiac arrest, liver failure, and renal failure resulting in death. Death trumps any putative benefit of convenience or costs that massive doses of psychotropic medications might reap for the hospital, prison, or nursing home. The patient, family, medical student, law student, MBA, and hospital administration and other stakeholders need to know why the lowest effective dose is the best practice. The first principle that the stakeholders should understand is the notion of physiologic reserves. Physiologic reserves are the excess liver capacity, the excess renal capacity, the excess buffering for exposure to acids or bases, the excess tolerance to heat or cold, the excess tolerance to carbon monoxide, the excess capacity to tolerate atropine or QT prolonging drugs before there is permanent injury or death. Other parameters are easily found by looking at the list of side effects in the FDA prescription drug labeling. This includes the prescribing information, package insert, professional labeling, directions circular, and package circular. I suggest the reader log on to the internet and find the package insert, the professional labeling, the direction circular, and the package circular for any medication that their family and friends take. Before the patient takes the first pill, he should read and understand the package insert that is given by the pharmacy with the medication. My exposure to psychotropic medications began in Lafayette Clinic in Detroit, Michigan in 1972. Lafayette Clinic was a psychiatric hospital operated by the Michigan Department of Mental Health. At one time, there were 16 state psychiatric hospitals in Michigan. At this time, there are only 3 state psychiatric hospitals in Michigan: Carroll Center in Carroll, Michigan, Kalamazoo Psychiatric Center in Kalamazoo, Michigan, and Walter Reuther Psychiatric Hospital in Westland, Michigan. Lafayette Clinic was unique among the state-operated hospitals in Michigan. It was a research psychiatric hospital under the direction of Dr. Jacques Gottlieb. All the patients admitted to Lafayette Clinic had to sign consent to be part of experimental research that could be published. I was told that one research project involved 10 to 15 grams of Thorazine a day. I don't know if this was a mistake on the speaker's part or merely an attempt to deceive a new and naive resident in psychiatric training. I merely repeat the statement to give the reader a flavor of the environment I was training under in 1972. I do know that 1 to 3,000 milligrams a day of Thorazine was within the range of possibilities at that time. A patient at Lafayette Clinic died from hypothermia caused by Thorazine. After that death, patients were monitored daily for blood pressure, pulse, temperature, and somatic complaints. Current guidelines for Thorazine allow up to 2,000 milligrams of Thorazine a day for mania and schizophrenic psychosis. When I was at Northville State Hospital from 1973 to 1975, I gave a floridly psychotic patient 100 milligrams of Thorazine, and he slept for 3 days. He asked me to reduce the dose, so I changed the dose of Thorazine from 100 milligrams at bedtime to 50 milligrams at bedtime. He did well after the medication reduction was ordered. In that case, I do not know if the patient was manic or schizophrenic and responded to the 100 milligrams of Thorazine. He may have been psychotic from methamphetamine, and when he stopped taking the methamphetamine, he may have slept for 3 days as part of the withdrawal from the methamphetamine, rather than a side effect of the Thorazine. In either case, a psychotic episode is often broken by a period of sound sleep. In psychotic state, it is better to induce sleep with Thorazine than with a sleeping pill, like Ambien, which has psychotic and behavioral side effects. Since that time, I have always favored low-dose psychotropic medications for two reasons. One, first, I did not see much improvement with medication increases after the initial dose. Two, second, I saw severe side effects with medication increases after the first dose. There are literally hundreds of side effects for any medication. Each side effect is a part of the physiologic reserve that has been stressed past its normal capacity to compensate back to the baseline optimum physiologic function. I perceived side effects as an indication that the physiologic reserve is being stressed past the body's normal ability to maintain the optimum homeostatic balance. The most significant physiologic reserve are listed under the black box warnings in the package inserts. Black box warnings usually identify sudden death as a side effect. The next most significant physiologic reserves are listed under the side effects of an overdose of medication. The least urgent side effects are then listed as common side effects and rare side effects. Occasionally, rare side effects can be very urgent. In the vulnerable patient, a common side effect can be urgent. Vulnerable patients are very young, very old, and very sick patients. Stress on the physiologic reserve can be acute with immediate adverse effects such as an allergic reaction or death. Stress on physiologic reserves can be chronic with delayed effects such as weight gain, diabetes, kidney failure, and liver failure. Tardive dyskinesia and enlarged breasts with milk production in males due to prolactin elevation are relatively common delayed side effects with antipsychotic medications. When I was at Northville State Hospital, the literature indicated that after a year or two in a state hospital, about 50% of the patients had tardive dyskinesia. This was because in state hospitals, the practice was to prescribe very high doses of antipsychotic medications. Drug-free holidays were common. The best example of acute stress on physiologic reserve is the LD50. Tomorrow we will discuss the LD50. Thank you for your time and your kindness. Have a great day.